Hello to everybody. Let me welcome you in the Department of Invasive Cardiology at Charles University Hospital in Prague. My name is Kovarnik. I'm head of this department, and I would like to share with you some of my insights to OpSens registry. This registry was designed for comparison between OpSens FFR wire with favorite FFR wire in each cath lab. Our primary aim was to compare physical performance in terms of pushability, crossability, torqueability, tip load, and overall physical performance, and also, which is I would say one of the most important things, to compare the occurrence of pressure drift between those FFR wires. Between years 2019 and 2021, in 27 PCI centers from 7 European countries, almost more than 500 patients were included in the trial. We use OptoWire in almost 300 cases. We were able to cross the lesion in more than 99% of cases, which is not surprising because the majority of lesions were in category A or B1. Operators reported OptoWire to be better than the routine FFR wire in more than 70% of cases. In more than 80% of cases, pressure stability was better than the routine FFR wire. Significant pressure drift, it means the pressure drift more than 3 mm of mercury, was seen in less than 5% of cases. We indicated PCI in 37% of patients, and in 92% of those PCI, we used as a guide wire OptoWire, which shows that OptoWire is as good not only for FFR measurement, but also for the guiding of our PCI. OptoWire proved that it's a very good wire with ability to cross majority of lesion in group A and B1. It has very stable pressure signal with very low pressure drift, which is in fact less than 5% of cases, and it gives us very good support for performing of PCI. The FFR measurement has 1A level of recommendation for performing of myocardial revascularization. OpSens registry told us that we have new type of FFR wire, OptoWire, which is very safe and very accurate in detection of myocardial ischemia. OptoWire technology offers us new type of the wire, which allows us to cross easily lesions, even tortuous lesions, gives us good support during PCI, and because of its very good pressure measurement, it allows calm and very precise both DPR and FFR pullback. Post-PCI physiology is much more complicated than pre-PCI because we cause some small emboli to the periphery of coronary tree. We induce the small attack of ischemia and reperfusion. We inject the contrast dye. So we definitely change the behavior of the endothelium. So the assessment of pressure gradient after PCI is more complicated than pre-PCI. But make long story short, good FFR post-PCI, meaning more than 0.9, has very good predictive value for good clinical outcome for our patients. So this is our target. So we can be assured that we did good job and we can safely discharge the patient. In case the FFR post-PCI is less than 0.9, the FFR can distinguish two basic situations. Either the pressure gradient is located inside the region where we implanted the stent, so it must be improved. Probably the most frequent strategy is post-dilatation, or the pressure gradient is located somewhere else that we put the stent. It means we need another stent. Or the last possibility is that it's a diffuse disease and we can do nothing about this, either with PCI or coronary bypass grafting. The ideal pressure guide wire must be at the first line good guide wire, so we need to cross the lesion if we want to perform the PCI. This is number one. The second step is to be good in transmission of pressure curves with zero or minimal pressure shift. And after PCI, we need guide wire, which is easy to connect and reconnect. And I truly believe that the OptoWire meets all these requirements.